Hey, I'm Scott, and we're going to talk about lung ultrasound. Specifically, I'm going to show you one protocol that's described and used a lot in the literature called the BLUE or bilateral lung ultrasound exam protocol. Let's get to it. Shout out to POCUSatlas.com for some of the images. Does ultrasound travel well through air? Charles Bronson says, nah, partner. The BLUE protocol involves scanning 3 zones on each side, and in each zone you're scanning 2 spots, so above and below. They used a microconvex probe in this study, which we don't have, but you can use either your linear array probe. You're only going to get to a depth of 8 centimeters, and for lung ultrasound, we really want to be able to get down to at least 13 when we're talking about things like B lines that show us that there's pulmonary edema or possibly a pneumonia. And then you can use your cardiac or your your cardiac or your curvilinear probe for looking deeper, and then also to look at the costophrenic angle down at the bottom of the lung where the diaphragm is. Normal lung ultrasound should look like this. We've got a rib on each side of our image, kind of our handrails there, and then your pleural line is nice and bright. It's just down here below the intercostal muscles. What happens to create these horizontal lines down here called A lines is the ultrasound impulse travels down because the air-filled lung and that tissue just above the pleura have drastically different acoustic impedances. Right, sound travels really different speeds in the two of them. All of that ultrasound is reflected at the pleural line. None of it's making it down into that aerated lung. Because so much of it's reflected, some of it actually hits the ultrasound probe and comes back down, or it hits some structure up here and is reflected back down. It hits the pleura again, and then it travels back up, and it might be interpreted by the machine that time. Because it spent a longer time away from the probe than the other impulses that were sent at the same time, the machine thinks that it traveled to a deeper depth, so it maps it lower. That's why you get these A lines extending down through the bottom of the screen. So these are artifacts that are created because so much ultrasound is reflected here at the pleural line. They're not actually, they don't actually exist down here in the lung. It just tells you that there's air abutting that pleural surface. Technique, we want to rock the probe, right? So we're going to place it on. We're trying to slide up and down until we get a rib on each side. And then we're rocking, right? We're rocking. That's imagining that a pin is going through sort of perpendicular to the axis that the probe marker is on. So it's going through here. We're rocking to try to get that pleural line as flat as possible on the screen. Next, we're going to fan, so we're moving perpendicular to that. Now we're imagining that pin is going through the probe marker for our fulcrum. And we're fanning back and forth until we see a maximum number of A lines. So we want to see all of those horizontal artifacts. That tells us that we're nice and perpendicular to the pleura, and we're going to get the best information. Decreased gain. This helps bring out those artifacts a little bit better. Lung ultrasound is all about artifact interpretation. The diaphragm oftentimes is higher than people think it is, and where you want to start generally is the bottom of where a bra strap would be, in that posterior axillary line. And then we're going to rotate our probe about 15 degrees just to dodge the ribs. So you're rotating the probe marker, which should be towards the head, down towards the bed. It's going to be clockwise, I think, on the left side and counterclockwise on the right. So this is an example of a normal lung ultrasound, and I've decreased the depth here so that we can emphasize the lung sliding. These are the 2 layers of pleura sliding against each other, our visceral and parietal pleura. If we use an M-mode line, remember that maps motion over time along every point on this line. What we see is in that chest wall, there's really no motion. So in the pectoral muscles and in that like fascia and stuff between muscle layers, no motion, just kind of flat lines all the way across. When you get down to that pleural layer, Because of that artifact and those two layers sliding against each other, what you get is this kind of grainy, chewed up, sandy seashore sign. So this is a normal finding on M mode that tells us that those two layers of pleura are sliding against each other, and that there's air deep to that pleura. So it's normal aerated lung there. So we got our beach and then kind of our serene sea up top. In a pneumothorax, what you might observe is a lung point. So this is actually the spot where the two layers of pleura have separated, and there's air interposed between them. So you've got sliding kind of distal to that spot, and then proximal to it, there's no sliding because the two layers have come apart. Here is another example of a pneumothorax, and what you see here is just there's no sliding. So those two layers of pleura are nowhere near each other. So you just get this nice static image, and compare that to our motion here. So notice how dynamic that looks at the pleural line relative to this. This is what M mode looks like for a pneumo, or when the two layers of pleura are glued together from like an inflammatory infiltrate or a cancer. What you see is instead of this sandy seashore, you get this barcode sign all the way down. So that's just showing us that there's no pleural sliding there. These are B lines. B lines oftentimes indicate pulmonary edema, but they can also be present for pneumonias or viral pneumonias, viral lower respiratory tract infections. What we're seeing is B lines start at the pleura, they extend all the way down through the bottom of the screen, and they erase the A line where they overlap with it. They also travel with the pleura. So as the patient breathes in and out, you see that B line move with the pleura. So those are all things that make it a B line. Here in this image, you can see B lines extend down, and when we follow that B line up to the pleural surface, it looks a little bit irregular up here relative to like in this image. In this image, we just see that B line kind of shooting straight down. But here there's like a little bit of a anechoic signal up there, almost like a little triangular density. So this was actually an example of a viral pneumonia and a B line kind of coming off the back of it. Here again is an example with some pleural thickening. So you've got this pleura, nice bright white, it's moving. You're seeing that sliding, and you're seeing this kind of laser light show of B lines extending down. These are examples of pneumonia. With pneumonia, it looks kind of how you might imagine. There's all this inflammatory infiltrate and pus filling those airways, so it's visible, the lung tissue itself. In this example, this is what we would call hepatization. The lung is so consolidated it looks like liver. And these are dynamic air bronchograms. So what you're seeing are these little pockets of air that are sliding around as the patient breathes in and out, and kind of making their way through these tunnels of pus. On the back side of this, we call this a shred sign. This is where consolidated lung is abutting aerated lung tissue. So you get this irregular border where these two tissue densities are very different. So lots of ultrasound is reflecting back up, and it's a nice bright line. And then deep to that, you're getting there. Some of that interstitium is probably edematous, so you're seeing these B lines kind of swing off the back. This is just a smaller pneumonia, but you're seeing again that irregular border where that consolidated lung meets aerated lung, and then some dynamic air bronchograms in here. Here's an even smaller subpleural consolidation. This is pretty common with COVID, especially in the basilar lung, and you can see some B lines extending down off of it. Again, small subpleural consolidation and then B lines. Notice how they erase the A line, they extend all the way through the bottom of the screen, and they move with the pleura. When we're looking down at our costophrenic angles where the diaphragm meets the lung, what we're looking for primarily is fluid. This is also a location where a lot of pneumonias end up, sort of in those dependent regions of lung. And from a technique standpoint, we're in the posterior axillary line. We're rotated just 15 degrees, pro marker rotated towards the bed, and you're at that sort of inferior part of the bra strap area. We're looking for liver, kidney, spine, and then diaphragm here. As the patient breathes in, you can see lung artifacts come down and sort of wash away the image. It's called a curtain sign. Notice that the spine extends to the level of the diaphragm, and then as the patient breathes in, it's sort of erased down here, right? That bright white line disappears. If the spine extends above the diaphragm, that's called a positive spine sign, and that tells us that there's fluid in that pocket that's transmitting that ultrasound down to the spine. So that would be a positive finding in a pleural effusion. On the left side, it's the same, just a little harder to see generally because the spleen's not quite as big as the liver, but all the same stuff. These are examples of pleural effusions. So you see this anechoic signal up here above the diaphragm. The spine extends well above the diaphragm here, positive spine sign. And then here you can see atelectatic lung. So as that fluid slips into that space, the air is squeezed out of the lung, and the lung becomes so consolidated it's visible on ultrasound. So this is what one of my mentors called the left shark sign, and what I like to call the wacky waving inflatable arm flailing tube man sign. And it has probably a definite name in the literature. I think it's maybe like shark tail sign or something. This is a big old protocol decision tree. So using all of the images that you just obtained in your superior and inferior zone 1, superior inferior zone 2, superior inferior zone 3, you're going to assign a profile and make a determination. If you see lung sliding everywhere, and it's a B profile, so you got B lines kind of in all the fields that you've examined, no consolidation, that's probably pulmonary edema. A profile, so you see those A lines everywhere, like in every field, they would do a DVT scan and look for clots. If there was a clot and it was A lines everywhere, then they would assume that that was a pulmonary embolism. If there was no clot visible, then they're moving on down to that posterior inferior part of the lung and looking for a pneumonia in the basilar parts. So if they see it, there's pneumonia. If they don't see it, then they're presuming that that's a COPD or asthma exacerbation. If there's lung sliding and they see these kind of mixed profiles, they call it pneumonia. If there's no lung sliding and they can see B lines in an area, then that tells them there's inflammatory infiltrate that's keeping those layers of pleura glued together, and they would call that a pneumonia. If there's A lines in a lung point, that's a pneumo, and no lung point, then they need a CT, essentially, or maybe a radiography, probably a CT. Yeah. So what finding does this exhibit? This would be A lines without sliding. Here there's a bunch of findings, but we've got an effusion consolidation here. This is a shred sign with B lines coming off the back of it. And then this is called a sinusoid sign. Sinusoid sign is when there's an effusion and the patient breathes in so that lung expands towards the chest wall. And then as they breathe out, it expands away. Right? It contracts away from it, and then fluid fills that potential space. This could suggest, so this is all normal A profile, and you can't really see if there's sliding, but this would suggest potentially a PE, could be a pneumo, and it could be COPD or asthma. And then these B lines everywhere, that could probably suggest pulmonary edema. All right. So scan each other's lungs, look top and bottom in each of those three zones, and try to generate things like that curtain sign, and try to do M mode in different areas. Make sure that you're able to see that sandy seashore sign. And when you're all done, maybe we can switch rooms and you can try another model.